Let's get everybody in that's coming in.
I'll let you know right after this. I had Scott tell me. Okay, you're live streaming.
All righty, welcome to the planning meeting for July 7th. We'll go ahead and call the meeting to order. I'm informed of no citizens wishing to address the committee, so we'll move straight to our consideration of minutes for the June 9th meeting. Any observations? Have a motion to approve? A second from Dorothy. Any question or discussion? All in favor say aye. Aye. All opposed, same sign. The minutes are approved. And with that, we will invite Dr. McReynolds and Dr. Garcia for a presentation related to the Da Vinci 11 proposal.
Yeah, right up here.
Afternoon, gentlemen.
And
welcome.
Mr. Chairman, let me tell you, and let me remind you all as board members and those that are watching our live streaming, that when issues come before you regarding scope of services or expansion of services, these have been vetted through medical staff and gone through a process. Dr. Weber asked an interesting question, and he said, when people come here, does that guarantee that everybody's approved of it? It's at a point where it's guaranteed that there is a need for a board discussion of this. I appreciate the surgeons coming today to talk about their needs. What we're trying hard to do is make sure that everybody, whether you are a physician or anybody at JPS, has an ability to express their interest in what services we should provide and how we should do that. Some of these are going to have financial constraints to them. Some are going to have answers that a board is going to have to look at. But it did go through a process before it comes here to y'all. This is not something we just throw out there. It is a process, and we as administration respect that process very much, and now it's the opportunity for them to represent their issues and their causes to the board. And I thank you all for being here.
Excellent. Welcome, gentlemen.
Thank you. Well, I mean, Dr. Garcia and I were out there talking while we were waiting to come in here, kind of reflecting on our years and years and years at John Peter Smith Hospital, working in the Tarrant County Hospital District healthcare system. And, you know, we just would like to thank everybody for the opportunity to not only come here today and present, you know, the status of robotics at the hospital, but also thank you for allowing us to have such fulfilling careers at the hospital district. Being able to help the poorest of poor and provide them the best of the best care has been not just fulfilling, but exhilarating at some points. Today, we'd just like to briefly go through robotics. Robotics is something that has been around for a while, and this is surgery actually done by a surgeon in a console remote from the patient's side, orchestrating the operation through robotic instrumentation. It has been around for a while, but only recently has really caught fire. Over the last, I would say, 5 years, I mean, there's been a logarithmic interest as well as embracing this technology by surgeons throughout the country. We've been fortunate enough to have Dr. Garcia at the hospital and in the Department of Surgery for 19 years now. And when he mentioned that, I said, where did that 19 years go? I mean, you know, I remember you come right out of residency, wet behind the ears, and you've been here 20 years? How's that possible? You know? Well, anyway, he grabbed robotics a long time ago, and I must say that when he grabbed robotics, I made fun of him. And I said, you know, this is gadgetry, this is not surgery, it's never going to catch on, and I've been proved wrong completely in this regard. As recently as just this last month, a resident who finished the Baylor program and worked with Dr. Garcia at John Peter Smith Hospital doing robotic cases, texted him after finishing the first year of her fellowship and said that she just performed a Whipple operation completely robotically. And you know, the Whipple operation is arguably the biggest operation that's done by general surgeons. And this is completely robotically, and that's mind-boggling. It is applicable in a variety of different fields, general surgery, with esophageal surgery especially, but also with colon surgery, urology, gynecology, gynecologic malignancies. It's spreading throughout the surgical community, regardless of specialties. We're increasingly applying robotics to surgical procedures, and as we push the envelope, we have more and more procedures that need to be done robotically. Then we have robots. There's three, well, I guess Dr. Garcia educated me. I thought we were on our 3rd generation robotics, but it's actually the 4th generation. We missed the 1st generation. Okay, but the 2nd generation was S, the 3rd generation was SI, and the 4th generation is XI. And the XI is the robotic instrument that we're going to talk about today. The robotics works better than laparoscopy because it has 2 cameras. Laparoscopy uses 1 camera, and you get really good visualization and optics with that 1 camera, but if you put the 2 cameras in there, you get 3D stereo optic visualization, and I mean, it's incredible. I mean, it is incredible. You're seeing muscle fibers instead of muscle. And because of that, it lends itself to safer, more precise operative techniques. You know, when I presented this to the executive committee last month, I guess, the 2 things that I told the executive committee was that, you know, we pride ourselves, I know Mr. Ehrlich feels this way, and I think everybody in this room feels this way too, is that, you know, we pride ourselves in giving excellent care to anybody that walks through our door. The best of the best care, not average care, not substandard care, not okay care. I mean, we want to give people the best. And in this day and age, robotics is the best. Robotics is something that is taking over. He and I were talking about this outside, that preliminarily 10 years from now, almost everything will be done robotically. That's how fast the technology is evolving. And so if we want to provide the best service that patients can possibly get in the surgical area, we have to be at the top of our game robotically. And this new instrumentation, I'm not a robotic surgeon. I'll let Dr. Garcia tell you a little bit more in detail if I ever quit talking. But you know, the robotic 4th generation is night and day difference. The S right now we can't even use. I mean, it's you know, you can't even use a stapler with the S. The SI is better, much better, and that's the one everybody uses right now. So we have 2 robots at John Peter Smith Hospital, only 1 is used. And the reason the other one isn't used is because, I mean, it's so inferior that why would I use that on one of my patients, you know, when I have this other one available. And the XI, the one that we're proposing today, is times again better than the one we're using right now. So, I mean, it's an enormous technologic step in the right direction. Now, the other thing that we do pride ourselves at the hospital about is we have a variety of different residencies. We have, you know, general surgery, an integrated residency with Baylor in Dallas, which means the integrated residency means that they don't have a residency without us. And so we're right in the middle of that. The residents at Baylor right now get their primary robotic training at John Peter Smith Hospital from Dr. Garcia. The surgeons at Baylor are embracing robotics just like everybody else in the country is, but they're behind in experience. And in order to allow a resident to do a procedure, you have to have mastered it. You know, and they are at the point now where they're getting to that point, but Dr. Garcia has been there for years. So I mean, he's been a huge asset, and as I say, I can't compliment him enough for driving this program because I was a naysayer the whole way along. But if we're going to train residents, and we're going to train residents at the level that they need to be trained, they have to have an intense robotic experience now. They cannot go out and practice and give the kind of care that they want to give to patients without being really, really good at robotics. And as I say, it's going to get more and more important as time goes on. So I'll be quiet now and let Dr. Garcia, talk. And he can tell you a little bit more of the specifics about it. I can just go through generalities.
I'd like to thank everybody here for the privilege of presenting this proposal, and also say thank you for the 19 years that I've had in Fort Worth and John Peter Smith. I was attracted to Fort Worth specifically to come to John Peter Smith when Dr. Weber was a member of the Department of Surgery, and
19 years.
it's been a very rewarding experience, and I've been grateful to be part of the mission that the hospital district has embraced as far as providing care for those less fortunate or those less able to pay for our care, or just the population we serve. I'm very grateful. It's been fantastic working with some of the best colleagues, not just in the Department of Surgery, but throughout the hospital, and dedicated personnel and staff, and the administration that has advocated so strongly for the well-being and the delivery of excellent care, safe care, and top-notch care for our patients. And it's along that vein that robotics nicely fits into the mission of the hospital. The proposal obviously is very expensive, the technology is expensive, but I think we could draw parallels to when laparoscopy was introduced. When we started doing lap choles, surgeons didn't want to do them because they could do a gallbladder removal in half an hour just through an incision, and people were very experienced and practiced at doing that. It was driven by patients. But later on, we did find out that the hospital stay, pneumonias, and other morbidity, return to work, was actually improved by this minimally invasive laparoscopic cholecystectomy. And the costs were huge initially, $20,000, $30,000, $40,000 for cameras, and then instrumentation and disposable. And yes, it's more expensive to do a laparoscopic cholecystectomy than it is than doing it open, but people go home earlier and you recoup the cost with length of stay, savings in the length of stay and the nursing care that has to be delivered in the peri-op period. Robotics, I would like to say that the open surgery was the old postal truck going across the country. Then you get to the propeller age where you have the lap choles. Well, if we want to venture transatlantically, you need a jet engine, and this XI machine is pretty much like the jet engine. It's going to allow us to do so much more. The S is excellent, and I did many cases with residents, and we operate on many patients, but if you want to see that the intestines are perfusing adequately, you need the Firefly, which the S does not give you. And another point on the S, the older system that we're using, is that in the next year or so, I understand that Intuitive will stop supporting it. So even if we want to use it, we won't be able to. So there's an imperative to replace that, and the replacement, I think, the best replacement would be the XI system. It is a big capital expenditure, but I think there are cost savings from various aspects of the care delivered with the XI. One is Medicare and insurers are actually going to be starting to pay more procedures done minimally invasively, be it that a hysterectomy, a colon resection, or any other procedure that currently is being done open. It allows more surgeons to become minimally invasive surgeons because you're operating, it's almost like you're doing an open surgery because you actually have hands inside. Laparoscopy, you put sticks in and you're operating as with chopsticks. It's like trying to build a boat with a grasper through a bottle. Well, imagine if you had that grasper and you had full motion and magnification, 3D vision. That's what the XI gives you. You can see blood vessel perfusion to the tissues. You have staplers. You have just phenomenal stability, and you can tie a knot. And if you don't like it, you could actually undo the knot. I've had undone, and if you try to do that laparoscopically, it would be almost impossible. So insurers will pay more or reimburse the hospital more for the procedure if it's done minimally invasively. But I also think, just aside from money, I really am a firm believer that it's going to improve care in terms of infection rates, in terms of patient outcomes, decreasing hospital stay in that respect. And, for example, many ventral hernias in many of our patients are done open nowadays. But more and more, there's a push that we should be doing these minimally invasively. But to try to sew laparoscopically is very, very difficult. The robot makes it almost simple. So we acquired, I believe, the Da Vinci in 2008, if I'm not mistaken, and I went to training and I adopted it and started doing cases. And it has been a battle at times because it's an investment in yourself in terms of sometimes cases take longer. Just like laparoscopic cholecystectomies took longer than open ones, but the patients benefited. With this same technology, yes, maybe you can do 5 gallbladders in a day as opposed to doing 6, but those patients do better. And I think there are patients, and I've had patients with the robot that even laparoscopically, we would not have been able to do it laparoscopically. They would have had an open operation, but the Da Vinci allowed us to finish these cases minimally invasively. And even though it's more arduous and more time consuming, I think ultimately our patients do better. You know, with the hernias, as I was talking about, you know, they really we have an opportunity to improve it. And in the handout on page 12, there's actually good data from one surgeon in Florida, Dr. Gonzalez, who actually demonstrated lower length of stay, lower recurrence rates. His recurrence rate went from 7.5 to 1.5%, and a complication rate that dropped from 10% down to 3%. The length of stay was also better. And so, I mean, there's clear evidence that's already out there that shows that you actually can have a remarkable improvement. And patients have less pain, so they get fewer opiates, so their intestinal motility is affected less. And the problems with narcotics are also decreased. So there's so many different aspects. I've had patients after a hiatal hernia repair go home without ever having a dose of pain medication. And so that's a huge impact. And there are many reasons for that. Dr. Lococo, when he was here with GYN, demonstrated decreased pain, lower blood loss, because you're more precise. You see the little blood vessels, you cauterize them, you tie them, you sew them, you do whatever you need to. But I think there's so many different aspects. So patient safety and better outcomes, improved reimbursement. Another thing that I think is critical is the training that we do for tomorrow's surgeons. We have surgeons here in Fort Worth already that came through our residency program, and obviously many residents in the future will settle here. And we want them to have the best training to provide the best care for Tarrant County. I think this gives us the opportunity, and it allows us as well to attract the best talent during our recruiting phase for new residents. We tell them, we will train you in robotics, we will train you with the latest machine, with the best machines. And we have one graduating chief resident this year that finished with 60 robotic operations. Very capable already. And so I'm very proud to be a part of JPS and be a part of the hospital staff, the medical staff, and be part of the mission. And I really am excited about the possibility of us acquiring this technology to further our mission.
Great. Thank you, Dr. Garcia. And to both of you, Dr. McGrail, Dr. Garcia, the feeling is certainly mutual. We appreciate the service, the years of service and dedication to the citizens of Tarrant County and our patients does not go unnoticed. And we appreciate you and people like Dr. Weber, who have really laid the foundations, quite frankly, for much of what's occurring today. So we appreciate your comments and certainly appreciate your efforts. Just to remind the committee, the process by which this goes through is this, after it leaves our committee, would go to finance for consideration. This is part of that multi-review process. It's already gone through the medical exec process. So I guess the only question, it is a question that's born completely of ignorance, but I read in your literature that it says the XI is not meant to be a replacement to our SI and SIE system, offering rather technologically enhanced additional system platform for the right surgeon, hospital, and marketplace. If it's not a replacement for what we're doing now, does that mean we have to continue operating the SI as a function of operating the XI?
The SI is still very functional and useful and has the blood perfusion, the Firefly that I was talking about, has a stapler, and it's excellent. S, the older system, is the one I was talking to, alluding to as more like a propeller. The SI is extremely capable. The XI is the later version, and it has some additions that really make it even better. But the SI, for example, if our colleagues in GYN are taking care of a patient with ovarian cancer and they're working in the pelvis, or if we're doing a ventral hernia where we're operating on one side of the patient, you can undock and redock with such great ease, and the camera in the XI will go on in any port. Currently, you go in with the SI with one port. So if you're doing an operation only in one area, if you're doing a hysterectomy, it's excellent. Doing a prostatectomy, it's excellent, or an adrenalectomy, or a hiatal hernia repair, or gallbladder. But if you're doing a multi-quadrant, different areas in the abdominal cavity, if you're doing a ventral hernia, for example, or an ovarian cancer, or colon cancer, where you have to operate here and then go to another part of the body, the SI is, you can do it, but you have to undock, double dock, it's very cumbersome.
Okay.
So what the XI allows you to do is to, with flips of button, the boom over the patient will turn around and allow you to redock without turning the patient around or doing all these other maneuvers.
It really
So
takes us back from, it takes us from what we had as 2 to now where we are as 1, back to 2,
you know,
in terms of the robotic capability. Is that right?
Yes.
Okay.
And so even without undocking, the machines work in concert much more so than with the SI, and you could turn around and operate behind you, which is, if you can imagine doing it just standing and trying to operate behind you, you couldn't. But with the robot, that thing will swing around, the arms will swing around without undocking, and it'll allow you to continue your operation. There's another big advantage in that currently, if we're doing an operation on the diaphragm, the patient has to be with their head away from anesthesia. So all the anesthesia equipment and monitoring, not that they're doing anything unsafely, but it's very cumbersome for them to extend the tubing to ventilate and continue anesthesia when the patient is 7 feet away from them, under drapes, under the robot arms. I mean, I think they really live a very anxious period of time when we're doing a robotic case, when they have to remotely monitor the patient. But with the XI, the head of the patient stays with anesthesia, and they are able to rest assured that they can see the patient, see the color of their skin, the oxygenation, and the monitoring is so much easier. And I think safety is a lot easier in that circumstance.
Excellent. Questions of other committee members? Mr. Chairman?
Let me make sure I understand. What we have on the agenda now is approval to go out to bid, then to finance?
No. This would go to finance before it went out to bid, is my understanding. This would go to finance before it was approved to go out to bid.
This is sort of a newer process for us as we go through this, but what we wanted to do is make sure that this planning committee was the first to see and understand whether it should move forward. Does this fit our scope of services? Does this go where we need it to go? It's the first level of approval, but then it has to be debated, we feel strongly as administration, that it has to be debated from the financial standpoint. And that is, this planning committee looks and says, this does fit our scope of services. This would be beneficial to our patients. Finance looks and says, now can we afford this? So you wouldn't go out for bid until you get final approval at both levels, and then you would go out and say, yes, we are going forward with this, because now it has the planning component and the finance component.
And ultimately, I guess the board votes.
And
after
the
the
board would
finance
ultimately vote, and
recommendation.
if y'all will just help us with a little patience here, no pun intended, but if you'll help us a little bit, trying to get this process to work properly and vetted properly.
Other questions? Dorothy?
If, with this new equipment, I know on page 10, you've listed some of the old procedures that we could do. What new advantage will this allow us to go toward?
Well, as I was alluding to, I think specifically it would facilitate those complex procedures that either are done open now or that require a lot of effort to try to double dock the robot or do them minimally invasively. I think as this technology improves, so when I started doing robotics in 2008 when the robot was brought to JPS, I was the only, and, you know, you have to push to try to improve care. But now, at this point, it was, I was the first one, and now there are 4 general surgeons in the department, and soon to be 5, maybe even 6, maybe everyone soon. Dr. McDonald doesn't know it yet, but maybe it actually makes the adoption of minimally invasive surgery very easy.
One of the things that you can do robotically is when you do a colon resection laparoscopically, it's usually laparoscopically assisted. And what you do is bring the intestine out through a hole in the abdominal cavity and do the anastomosis outside the patient's abdomen. With robotics, as he said, you can sew with a robot, just like you can sew. The visualization, the hand-eye coordination is exactly like it is open. Laparoscopically, it's not. It's much, much more difficult to sew laparoscopically. So you can actually do an intestinal anastomosis, hand-sewn, inside the abdominal cavity, rather than having to bring it out to do it, which means smaller incision, you know, and less morbidity. The Whipple operation, you know, I mean, she's not the only one in the United States that's done a Whipple operation robotically, and I think it's only a matter of time before we do our first one. So I mean, you know, I was talking to him also about vascular surgery. If vascular surgery was doing more open procedures now, you know, most of their procedures now are done endovascularly, and they don't open people to do aortic bypasses or aortic aneurysms and things like that.
Correct.
Because they do it endovascularly. If they were doing those now, they would be heading towards robotically doing those. Because not only can you do intestinal anastomoses, you can do vascular anastomoses robotically. Trying to do one of those laparoscopically, I mean, is mind-boggling.
I think what we'll see is a process by which Dr. McReynolds will get on email, and from email, then he'll get on the robotics program. So it's a step process.
I think I might be robotic
Progress
before I'm
is-
email.
advancing,
you know,
really?
Email
Okay.
already. You
Because
know.
email's been around for a while.
I'd
It's
probably
just
be better
for-
robotically than I am email.
I understand.
He can already tie, he's been at the console and can, on the simulator, tie a knot. So there is hope.
Good. There's hope. We're all holding out.
Can't tie his shoes, I mean, what?
Charlie?
But again, our reason, our vote today says conceptually, we agree that there is a need that falls within our scope of services.
Fits within our mission.
And
Yes.
And it's within our mission, and we're gonna move forward where finance would then get into the details of the cost.
Yes, sir.
And I know we have 2 of them. If we get a third one, if there's building capital, if we gotta do some expansions with a third in, finance would consider all those financial aspects and then bring it back to the appropriate committee, ultimately to the board.
It would go, more than likely go to full board. After it's gone to planning, after it's gone to finance, it'd go to full board.
If I may interject, you know, the question arises, can we afford this? And it's a big capital expenditure, I understand. My question is, can we afford not to? Because I think we will leave a lot of money on the table from payers in terms of reimbursement if we do not adopt this. And the S is going to go away. So the question is, what are we gonna bring in its place? We are training residents, and we are providing care for Tarrant County patients. And I think the volumes, last year, there were 279 cases done robotically at John Peter Smith. Of those, 30 were done on the old system. All of the rest were done on the SI system, which is functional. The S just cannot perform. And so there is competition for time, for access to the SI. In many cases, sometimes we ask, can we do it on a certain day? And Dr. Mishashenko was struggling with me this last week with some complicated patients that had come in. And just trying to find the time. And sometimes there is no robotic time, it's all taken up. And so we sometimes resort to doing things open that could be done minimally invasively. So it's the cost in dollars as far as reimbursement, and the cost in terms of the increased cost of care for patients that end up staying longer, end up getting more complications. Hernia recurrences are very expensive. And I think in that sense, this system will pay for itself within 2 to 3 years.
Mr. Chairman.
Yes, sir. Mr. Chairman?
Two things. One is, one thing about technology is the one animal that gets old as fast as it becomes new. It outgrows itself as soon as you, and I think that we would really be remiss if we did not move it forward, so I so move that we,
I have some questions.
Mr. Jordan.
As I did some just basic outside research, and there's a couple of critical folks that have other things to say about it. I wanted to see if I could just look at the math a little bit. And I'm looking at, these are unpaginated pages, but it looks like page 7 of this book, whatever it is online. Potential increase, 100 per year of the hysterectomies, 140 of colorectal, 75 thoracic, and it has the cost of investing, not investing. We have various things we can do with our $2 million, right? We could invest that into other people instead of machines. So whenever I look at this, I want to say, if I spent that $2 million on people, could I do and get better? I've heard you say that you could get more from the providers if you do these things, machines. But I don't see anywhere where it says that. I mean, and I've seen these a couple of times. We see these reports where we can make all this money if we do this, but I never see the comparison to spending the money on people, and I don't see the real math. I'm glad to see some numbers, that's nice, but when you have $274,300 per year for hysterectomy, where does that come from? How are you getting that?
Well, so this specifically, I think, talks, if you take the reimbursement from Medicare and other insurers that are actually now paying more, and I didn't break it down by, like, there's so many insurers, it's hard to do so, but Medicare is starting to do that, where they will pay you more for a minimally invasive hysterectomy than for an open one. And I don't have those numbers at my fingertips, but this is just an estimate, that if you took all those hysterectomies that are done open and converted them to minimally invasively, that this is a ballpark figure of what you might recoup in a year. So that's just in terms of reimbursement.
But is that the difference, or is that the
Yes.
total?
Yes.
So you're saying whatever it would have been if we did it by hand, it'd be $1 million, but if we do it by machine, then it'd be, we would get 1.274 in, instead of just $1 million.
I'm not,
Okay, if you look at the cost of not investing,
okay.
it says hysterectomy, $274,300 per year.
Correct,
Okay.
correct. So, yes.
Okay, so
So-
you're saying that if we bought this machine, then these 4 numbers could be added together, and I get, say, close to 3 plus 6 is 9, there's 16, there's $2 million, so you got your $2 million a year. So you're saying we make our money back in 1 year?
Well, you know, I don't wanna say that, because I think, of those 100, maybe half of those, maybe 80 of those can be done minimally invasively. There are tumors that you will not be able to do minimally invasively. So I think that's just like what's being done open, that potentially, it's almost like gallbladders. You know, when we started doing laparoscopic cholecystectomies, at first it was, 20% got done laparoscopically, and then we'd cut them open because we were unsure of the anatomy. So each year, and now I think I'd venture to say 95% of our lap choles are done laparoscopically. Whereas when you first started, maybe not 100, maybe we do 20, 30, 40, maybe 50. And we're training more GYN residents and staff that are now doing cases robotically. We have one urologist that does some cases, and I don't think they're even listed here. It's not even listed. But I think we need another urologist, and I believe we're going to get one soon at some point. And I think the standard of care in robotic for prostatectomies is minimally invasive robotic prostatectomy. So if you get reimbursed more, and let's say $2,700 more per hysterectomy done minimally invasively, and not just robotically, but laparoscopically as well, then that adds up to that sum. I'm not saying you're going to recoup all that $2 million, but maybe you get $500,000, maybe $1 million in that first year.
Well, Doc, you got this is a calculation, you get a number, 274,300.
Yes.
I'd like to see where that number comes from.
It comes from the difference in what is being reimbursed for minimally invasive hysterectomy versus open hysterectomy. So you multiply the
So 100?
100
Years.
times,
So difference is $2,700?
That's my understanding. To the hospital as far as,
So let me make an observation as it relates to this committee, and I don't want to cut off good conversation, but I certainly don't want to deprive my colleague, Steve Montgomery, of the opportunity to go through all of the financial vetting that I know he will definitely want to do. In the interest of time and in this committee's focus, let me suggest that we keep the financial questions and financial analysis saved for the finance committee, because there's going to be a lot of people that want to see that and be a part of it, and there's no point, in my opinion, in replicating that.
Okay,
If we can focus on whether or not this recommendation is consistent with the mission of the hospital system, then I think we are living within our scope here and not getting into Mr. McCullough, because I don't want him to chase me down in the middle of the
Well,
night.
I have a question about the actual efficiency of it. You've made the point, you've asserted that people go home earlier. There's one, there's at least this one study I saw, maybe two, that said that 80% go home in less than 2 days compared to 75% who have the regular surgery home in 2 days. Are we talking about 5% difference?
which page are you, which procedure?
I'm on a study that's not something you gave me.
You want a study?
I did actually outside work to see if something about this. Is that consistent with, is that consistent, what's that?
I missed the question again.
Okay, I've got a study, and I don't pretend to be an authority on this, is why I'm asking the authorities. But there's a study that said that 80% with the robotic surgery went home in 2 days or less, compared with 75% who had the laparoscopic surgery regular. So the difference is 5%. Is that consistent? That's not anywhere in your documentation.
Okay.
That's a study that I found.
Okay, which procedure?
Laparoscopic hysterectomy, I believe.
Okay,
Yeah.
so that's hysterectomy, and I don't know which study specifically you're looking at, but
have to
it
see
does
the
show a
study.
5% improvement, okay, that's not huge.
I can buy a lot of people for $2 million.
I understand, but if you look at complications, let's talk about ventral hernias and what Gonzalez has published or presented at national meetings. This is not my data or anybody, but on page 12, if you look at the recurrence rate and the complication rate or the infection rates, it doesn't specifically bring out complications, but specifically they're more typically alluding to, and this is laparoscopic versus Da Vinci repair of ventral hernia. You have a fourfold reduction or fourfold increase in recurrence rates with laparoscopic repair. If you reduce your recurrence rate from 7.5 to 1.5%, and he had 134 patients in his series, which is a nice number. That decrease in recurrence rate, and recurrences are very expensive in both morbidity for the patient and in terms of costs for a hospital system. So I think you could improve outcomes, not just the cost. Maybe in that study you're referencing, there was a reduction in hospital stay for 5 patients out of 80. So it's not huge, but if you improve outcomes, as this paper demonstrated, or this surgeon's experience demonstrated, and this gentleman was I've heard him speak, he's a very experienced laparoscopic surgeon, very good, and yet he was able to still demonstrate a significant improvement in outcomes for his patients.
I think one of the things that you could use as an analogy is that we're not pushing to do cholecystectomies robotically. And the reason we're not is I think if you took 100 people with laparoscopic cholecystectomies and did 100 people robotically with cholecystectomies, you'd find that the complications, the length of stay, everything would be fairly similar. You see, the people that are going to benefit from from the robotic technology are the people that have more complicated things than laparoscopic cholecystectomy. Laparoscopic cholecystectomy is a standardized procedure now. It's the way to take gallbladders out, and you can do it very, very safely with very low morbidity, and people go home the same day. So trying to improve on that with the robot, I don't think we're going to make much improvement. But then bigger procedures, for example, like colon resections, a lot of the genitourinary tract surgery, Heller myotomies, splenectomies, things like that, that are much easier to do robotically than laparoscopically, or where you're gonna get the bang for the buck. It's not comparing, like hysterectomies and cholecystectomies, comparing them laparoscopically and robotically. I mean, I'm not the expert either. But I think that those, if you have a standardized operation that works really, really well laparoscopically, it's gonna be kinda hard to say, well, we need to do this robotically. If you have operations that you can do laparoscopically, but they're cumbersome, time-consuming, fraught with bigger incisions, and you can do a better job robotically, then those are the people you need to compare.
Mr. Powell?
I was just gonna say, and I think my colleague to the right has raised some good questions. As I said earlier, before Chairman Emerson made the motion, today we're conceptually approving the falls within the scope. I think we can send those questions and maybe some more to the finance committee and certainly vet those with the finance committee. I won't embarrass myself in front of Dr. Garcia, who I know has given 19 years of his life to this institution, and start trying to talk about surgeries, but our mission is also quality. And I keep hearing robotics versus open, length of stay in the hospital, what time, what quality of care. So again, I think there's a lot of financial questions still left to be answered, but I think that falls within fiduciary finance. And so being, Mr. Chairman, I'd make a second to the motion on the table.
Okay, so we have a motion by Reverend Emerson and a second by Mr. Powell. Is there any question or discussion?
I have a question about the scope of the committee.
Yes, sir.
Are we here to approve of anything that's gonna make the quality of an operation higher, irrespective of any other bell or whistle, any other?
It's a subjective question. I think the question comes down to whether or not you, as a voting member of this committee, would conclude that that answer fits the mission of the hospital system. Because I don't want to subset our mission. Our mission is based on the entire JPS system and the welfare of a JPS system and our patients. So however members choose to subset that and decide how that vote works, it's a subjective area. I don't think I can answer that question. But I do know that the purpose of this process was to create a means of taking an idea all the way through and vetting it to the point, long before it even gets to us, that even the doctors, med exec, go through that and vet that process. I don't think any of them are saying this is a must-do, you have to do this or else. I think it is a policy question. And every function of the hospital's committee structure has got a policy question to ask. There's no question finance has a policy question. And I may have finance questions when that comes up. Our function is based on whether or not it's consistent with the mission of our system. So I think they're all legitimate questions, Mr. Norwood. I just think it's a question of, from our perspective, is this kind of advance consistent with the mission of JPS? If you don't believe that it is, then it's a vote of no, no question about it. But if you believe that this is a process.
What is the actual proposal on the table?
The proposal on the table is motion to move the recommendation to finance.
Okay, so the motion is nothing more than to move this forward to finance. It's not to say that we should spend $2 million and buy.
That's correct.
No.
Reverend Emerson, I don't want to put words in your mouth, but I understood your motion to be that this would be forwarded to finance.
I have several questions, but they're not for this meeting.
Right. So your motion was to move the recommendation to finance to continue vetting.
Can one thing?
Dorothy?
I think part of what this committee's role was to do was to have a forum where when different groups or doctors were asking things, that they would come, present their information at this committee, which was part of the planning. We would look at it and see if it fit into the scope of services, see if it's appropriate, and ask some questions about patient care and say, okay, this looks like something that it fits in with our mission. But that's not saying it's gonna be approved, because it's gotta have some more financial information coming back. They've gotta prove some things when it's come to finance about looking at the length of stay. You just can't say it's gonna do it without having some more explanation. So finance has a bigger piece, but for us, it was kind of saying, okay, it fits into what we're doing. We're doing some of it now. I can see that it would be a benefit But I'm not sure that when it comes down to the final deal, I'm gonna vote for it, because I don't have enough information yet.
I think the analogy that we can use here is to separate the cost completely from the recommendation. And the analogy would be, for example, should the hospital system begin performing sleep studies? Well, that's a legitimate question that regardless of cost, comes to the very function of whether or not it's consistent with our mission. This one, because of cost, obviously it raises everybody's eyebrows. But if this were $1,000, then I think my answer would still be exactly the same. This seems to me to be consistent with the mission of the hospital, and the financial question is one that someone else gets to deal
Or
with.
vice versa, it's $1,000, but this does not fit our mission.
Right, in which case
This
it
is
would be
not
no.
what we do. So it doesn't come out of this committee.
That's right.
This committee's role, and it's been hugely positive, because it's been quite evolutionary, that we get our physicians before a planning committee to talk about what they see the future and where they see that going.
Which is awesome.
You bet, and I think it's great. This committee is merely saying, that does fit our mission, or no, despite the cost, it could be free. Doesn't fit our mission, it's not what we should be doing. So that when finance gets it, and y'all debate it at the finance level, you know, getting to you at a finance member's level, that it's been vetted fairly, one, to see if it's valuable to the physicians, and that's gone through their process, and two, this is part of our mission. Now, maybe part of our mission, but sadly enough, we just can't afford it. Or, this is great, it's part of our mission, and we're gonna take some money over here and put it into this because we believe in this. That's what this is about. So this is a process. And I
Finance.
think it's valuable.
Finance.
As we indicated earlier, Mr. Chairman, like I said, we're only sending to finance to vet out those financial issues. It may be more than $2 million. It may cost dollars to reconstruct the rooms,
You
put
bet.
someplace finance.
And you could easily
Total cost,
see,
just equipment.
Mr. Noreen, you could easily see the possibility of planning, looking at it on its value and saying, this is very valuable, and finance saying, and even the same members. Mr. Petty could say, if I am a judge and jury on this, my attitude is, this fits our mission. That was my question. Now my question is, can this organization afford it? And my answer to that is, sadly enough, no, or yes, we can move forward.
So lots of discussion, and we have a motion and I have a second. Do we have any further discussion? Okay, if not, then all in favor say aye. All opposed, same sign. That motion carries. Gentlemen, thank you very much for your time. We appreciate your patience in allowing us to vet the idea and willingness to come and present to us today.
Thank you.
And thank you not only for coming to this meeting, thank you for what you do at JPS.
I would be happy to try to get
That's
some
a
more.
great idea about this.
I will have questions at another meeting.
Undoubtedly.
We want to say-
Thank you. Yes, we are going to have a closed session. Not on this topic. Not on this topic. All right, so I'm going to invite Angie to come up. Angie, if you don't mind. Let's consider our committee reports relative to design and construction projects. This is on page 30 of your packet. Welcome, Angie.
Thank you. I'm not asking for any action on anything today. This is just a report.
Approved.
All right.
Thank you.
Bring you
Approved.
up to
Thank you for
speed.
coming by.
Can I make a motion, Mr. Chairman?
Sharon's in the
There's no
room.
motion
I'll
needed.
ask for your money. Okay. Our first project on the list is our radiology x-ray replacement. That's a CT and general x-ray, 2 of each. It's active and ongoing. We're getting really close to the end of that, and I know radiology will be happy. We've got about 30% more, and we'll be finished with that one. Our lab upgrade phase 1, clinical engineering. The notice to proceed was issued to the contractor on June 30th. So he's currently mobilizing. He gets 21 days to mobilize before he actually starts working. That's planned to finish in October, so that's important. It is a project in the basement of our hospital, and that's always a wild card anytime we have a project in the basement, but we're hoping to be successful. The third one is our Northeast Tarrant Medical Home, and Mr. Chairman, since that's the next item on the
Yes, you
agenda,
may
can
go
I
straight
right
through.
into
Since
that?
we don't have to vote on the first one, you can consider that as accepted.
Okay, any questions on the first two?
Angie?
Yes, sir.
If you'll multitask and just move that screen, you'll see those slides. Because there are slides on the
Oh,
screen
fantastic.
that go to,
There should be a
The clicker is,
Oh, there it
Ah.
is.
there you go.
There it goes.
I'm just
Okay.
here to help you, my
So the
man.
last box is Northeast Medical.
But now,
It was.
you need to.
It was the last box.
I want to click to the next one.
There you
There you go.
Success. Always happy when we're successful.
She's
Fantastic.
construction, not IT.
Okay, that's it. That's exactly right.
Thank God it's not
Okay.
me over there. I never
Thank
would've got
you,
the
Robert.
slide.
The first slide is showing just the initial placement of the clinic for our Northeast Tarrant Medical Home, located at 3200 West Euless Boulevard. If you'll remember, we purchased the property. It's a little over 11 acres, probably about a year and a half ago. Where the building is sitting is the high point of the property because we don't want to do a lot of backfill, anything to add any more cost. It's also over to the east side of the property along Raider Drive, which is a two-way street. West Euless Boulevard, which is Texas 10, is one way, and you'd have to turn around and come back. So we did want a close interest over there on Raider Drive. Reverend Emerson, this is just for you. 194 parking places, which is 3 more right now than Southeast. So I know that came up last year in Southeast.
We'll share our 3 spaces with
So
you.
that's planned. So we think we have plenty of parking planned. For our employees' benefit, we're putting employee parking in the back, and they'll have a back entrance, which is always a positive with our employees, and another 110 in the front. So that's what it's looking like.
Fantastic.
Yes, sir.
And
Yes, sir.
you
Wanna
gonna
go back?
show us another drawing?
Oh, I'll go back.
No, go ahead.
Go ahead. Okay. Okay, so this is where we are so far. The area that looks kind of pink to me, I hope it looks pink up there for y'all.
It does?
That
Not to
is-
Mr. Early, but to us, yes.
I was gonna say,
Robert won't
yeah,
know.
where are we going on that, Chuck?
That is the
Where's the
clinical,
pink?
clinical side.
Left,
Yes,
left
sir.
side,
Yes,
the
sir.
horizontal
Towards the
bar.
west. The clinical area, that's the clinic itself, has been decided, that is it. We don't anticipate making any changes. We have actually had 7 meetings to get to that point. It's got 24 exam rooms and 2 treatment rooms. Very nice. Everything's done very efficiently, laid out in the leanest method possible. We don't want our employees to have to walk all the way to one side or the other, so you'll see it almost mirrors each other. On the right-hand side, you see dental, education, imaging, pharmacy, and behavioral health. Those ancillary services, we're meeting one-on-one with the directors and managers of those departments to get those laid out. We've had 2 meetings with each of those, except pharmacy and behavioral health, only one with those, to get those laid out to fit. The pharmacy on the bottom, which I think is interesting to everybody, and I think it's a good thing, we're gonna put a drive-through there, so you'll see the drive coming through. It's got its own waiting room. Imaging is planned to have general x-ray, ultrasound, OB ultrasound, future bone density, and regular general x-ray. That'll all be in there. They have their own changing room. We did have a post-occupancy evaluation on our Southeast Medical Home, so we're taking what we learned from that, and one of the things we learned in radiology, folks don't want to walk by any kind of doorway when they have a gown on. So they have their own dressing room planned to go inside there. Education, that's really conference and training. That's preliminary design. We'll show that to be divided up into at least 2, if not 3 smaller rooms, so that'll be good. Dental, that's gonna have 4 chairs. We don't have that floor plan laid out yet, but that's to come. Behavioral health will have the one-on-one meetings with the physician, so that's more like an officer consult setting, as well as a partial hospitalization program. So that's why behavioral health might look a little big to you, but, so it's got 2 functions in there. The gray area is the building support. And down in the little orange in the center, that would be check-in registration offices for front-end staff that need to be at the front, your managers and things like that. We've got bathrooms on the front end. There's bathrooms scattered throughout. Originally, this looked like a little crooked, maybe Italy, with a little turn there on the ancillary side. But really, with those angled walls, it's a waste of space. So we just straightened it all up. I think it's looking pretty good. The next slide. Discussion only, y'all. When we originally talked with the staff and just different folks, the Northeast Advisory Council, we've met with them, the physicians out at Northeast. They really want a warm, welcoming feel, so that's, a lot of wood, a lot of brick or rock. evidence-based design really tells you that nature helps you heal. So a lot of natural looking finishes, nothing, we're looking for durable that looks good. If you see the colors over on the left, JR, please don't have a heart attack. But we're looking at maybe incorporating our colors that are around the logo over in the building, and we would use the exact color just to give it a little, a little fun. And those are actually planned, it's hard to tell in there, but it's on the wall and then it comes out like a bench. So that'd be pretty cool, we think. And also a covered drop-off and pickup, and that was something that came out of our Southeast Lessons Learned. And last slide again, that's just showing you what the building could look like. We've got a lot of windows in the front for natural light, but those will be, tinted or shades or whatever we do to help with the electric bill out there. But the light really helps. So do we have any questions on this one? Yes,
Any
sir?
questions?
So, one is, has the architects or anyone met with the staff at Southeast to talk about some of the things they would have changed or would not
Yes,
have
sir.
done?
Yes, sir. We did that post-occupancy evaluation, and actually we have a report that's probably 20 pages long. A lot of it was what did we do well, and then what did we need to improve on. And one of the things that really stood out to us was the radiology. You've got a gown on. You don't want to walk by an open door. I wouldn't want to either. However, we didn't think about that. Another one that was day one, the registration staff is sitting. A man goes in the men's room. Well, you've got a perfect view of the urinal. So we had to fix that right away. Just, it's on and in things. You look at it on paper, it looks good, but when you actually get in there, there are several things. We have talked to the staff. We did get their feedback on that, and they had a lot of good things to say about it too, so that makes us feel good. But we learn something every time we do one.
The other, two remaining. One is, not so much I'm concerned about the parking,
Yes, sir.
because I'm really concerned about the square footage of the building. And the square footage of this, how does it equate to the square footage of Southeast?
This building is smaller, but it's proportionate to the connection patients. Southeast is about 48,000 square feet with about 12,000, that we lease to City Trends. So overall, in the future, it could be 60. This one, as it sits today, is a little less than 35,000. We're hoping for 30,000, so we're still massaging this a little bit just to get the best use of the space. The current Northeast space that's a lease is a little over 27,000, but it's a really inefficient space. So what we're trying to do here is make this efficient where we don't need to spread out, but the space we do have is used very efficiently, and we have room to grow. In the future, if the population increases and our connection patients increase, we do have room to grow, and just forgive me for just a minute, I have to look at my site plan. We can go to the north and we can go to the west if we needed to expand. And that was something that was asked for early on by administration, was when we were laying this out, make sure that we were able to grow. So it's designed where we could grow to the north, we can grow to the west.
That's one of my main, I've been saying that all along. I just
Yep.
don't want us to
Yes, sir.
do a cookie cutter and then we, too small to begin with.
The other thing, Mr. Chair, to that is, you want to try to figure out size proportionate to patients
Right.
best you can, and then leave your best options for growth.
Right.
Because you're never quite sure. We can look at demographics, but things can change. And that's why I think you as a board made a smart decision to buy the entire 11 acres. But because you don't want to get criticized by taxpayers that say, you got a lot of vacant space out there, you don't use your space. So we've really tried hard to look at the patient volume to equate to the space we need with the luxury of having space to grow. And that facility fits both of those categories.
Yes, sir. And
Then
go ahead.
my last question
Yes, sir.
that I really hate to bring up, I just don't want us to get hit in the face. I was in a meeting all day yesterday
Yes, sir.
with the big issue that's going through town now is transgender.
Yes, sir.
Are we gonna look at that or will we look at that?
Thank God that's not on this agenda,
Yeah.
which means we can't talk about it.
Right.
It's never on the agenda.
Reverend, when we looked at this, all the bathrooms throughout the clinic are for male or female. The only ones we designated in the front for male and female are the two front, and both of them will be family friendly, so they'll have the baby table in there and whoever can go in, but we didn't get in great detail with that. But within the clinic, if you're a patient in any of these areas, there's a bathroom, you can use it.
That's a finance committee question anyway.
That's right.
Yes, sir. But I did,
Sounds like campus services.
I think it's accommodated if they have a single bathroom.
may I point out one thing that I know is gonna be different the next time you see this, so I wanna point it out now. On our slide with the site plan, in the very front, the little bit of blue, well, it's hard to tell on there, but in the little triangle that's blue, that's the retention pond where if you get a lot of rain, it's gotta have somewhere, it's not a big pond, it's 2 or 3 inches really, that's gonna hold the water. But once we looked at that, we thought, well, we don't want that in the front of our building, so we're actually moving it up over where it says Raider Drive, that little triangle there. It'll go over on the east side. And what that does is it just holds the water for a few minutes because we can't dump all the storm water and the storm drains right, off the bat. It's gotta trickle in slowly. So that's all that's for. We're not getting a big water feature in the front.
Well, whoa.
Yes, sir.
But you don't want a eyesore also with it being a retention pond. That if there is dollars, that I would ask that we look at it to make it something that can be used. So in other words, if it's a fountain or something, so when it fills up, I've seen it happen.
It can be aesthetically pleasing and can serve that purpose.
Because if you just put pond in there, you're gonna get mud and
We're hoping it's, can be grass and just, hopefully just holds the little bit of water in.
Well, and we don't
But we'll
wanna,
look at it.
we're not attempting at all to enhance West Nile to increase
No.
patient volume out there.
No, it
So
literally
we do
doesn't,
wanna
it
Nice
literally
standing
doesn't stay
standing
in
water
there.
there. That'd be the best.
No,
be smart.
no
I
patience.
think.
All right, any other questions for Angie?
Yes, sir.
Angie, thank you very much for your report. We appreciate it. No, there's no action on this, so we'll move straight to live streaming of public meetings. Mr. Early.
To give you all an update, again, I appreciate the county and Mr. Manius and the team that's putting this meeting together. This will be the last meeting that we have down here, and we will give you all an update
Doggone it.
on that again. We can amend that, should either one of you two chairmen wish, but
Now, since you've gone to all the trouble.
GK is going on that.
yeah, well, GK, if we can just guarantee some cookies coming, we're okay. But what I did want to say is that David Mendenhall and J.R. Labby and her team have done wonderful work in trying to make sure that when we go back for our finance meeting, which is a combined board meeting, that we will be prepared on a temporary basis, but we're not going to sacrifice quality. So we've got a company that's going to come in and bridge us. We went out this week for an RFP for services, and we'll go through that process.
Is it robotically going to make sure everybody can?
Oh, my word.
It depends if it saves money.
It's a financial question, I'm
Improve
sorry.
Yeah. So what we're going to do is be able to bridge that. We'll still have, when you all come back over to JPS, we will be digital. We'll have everything that we need. We'll be live streaming. We'll be exactly where we want to be with the quality that they have here at the county. And then we're hoping by October, we'll have our permanent system in. We feel good about that, but the RFP was let this week, and we'll go through that process. But I wanted to let you know that we're not going to sacrifice anything. And a great thanks to the county for allowing us to do this and allowing our meetings to be open to the public that couldn't make our meetings immediately. And I'm happy for that and what we were able to do.
Excellent segue to Mr. Manius to talk about long-range planning RFP. Good afternoon, GK.
My presentation was very, very short. By the way, I'm not really that hurt about the fact that you all don't want to come back and visit with us. My question is, those comments weren't based on parking, were they?
No.
Okay, because I have a short story before I get going. You know that I'm on one of your committees that meets down at the hospital district. And I guess a week to 2 weeks ago, I pulled in and I parked between Mr. Early's vehicle and Bill's vehicle. And
I know where this is going.
I don't, I like it.
So, I don't know if it was Bill or Mr. Early that ran to the hospital district police, but I got a ticket.
Cool.
Let's set the record straight. It was not Bill or me that ran to the police. It was Bill and I that ran to the police together. We both got there at the same time. And what we suggested was a boot, and police said, no, we'd rather just do a ticket.
Well, you know, the interesting thing about that was Bill was getting out of his vehicle, and he never said, hey, you're not supposed to park here. So,
We've all been chased down by that little lady before for being in the wrong place.
she chased me down this morning too.
We're all familiar. I've given her my card and she's memorized my face, so I've got a pass, but you gotta spend some more time down there.
Let me very quickly bring you up to date on our long-range plan. Just some timelines, and I won't take more than 2 or 3 minutes. As you know, in the first part of March of this year, we went to the Commissioners Court and talked to them about a process by which we could jointly work with the hospital district to move this effort forward. They agreed on a 4-step plan. They agreed upon a four-step plan that required at least 2, possibly 3 RFPs. We went ahead then in April and brought the first draft RFP to the court for them to look at. We've worked with your staff. In fact, your staff has been intricately involved in all aspects of this. We've had discussions with board members. I believe we've covered all the board members now, and we appreciate your time. We went out then on April 19th. The court voted to go ahead and move forward with this. It was a unanimous vote. Just to make sure that everyone knows that the court is fully supportive of this effort. On May 9th, interestingly, on May 9th, we had a mandatory pre-bid conference. And we do this on any major RFP that we submit. There were 40 different firms that attended that. There were 52 people in attendance. Mr. Early and I led that effort. Actually, it was one of our people in purchasing that really steered that process through, and we answered questions. So finally, we got the RFP out on the street. We had the mandatory pre-bid conference, and then we did receive on June 6th 8 responses to that. Out of those 8, 2 were no responses, which we appreciated. So we know that there were people that were interested, but felt like they couldn't bid on this particular issue. Since that time, we have a joint committee that consists of staff of our office, other elements of the county, and with the hospital administration staff. And we have vetted those 6 and have vetted those down to 2. And Monday, we are going to have oral presentations at the staff level. I briefed the court on our progress probably 2 weeks ago, and the court was very clear that they wanted presentations to them also. And so we are looking at hopefully the 19th of July. And we invite you to be part of those presentations. We'll make sure you get the time and everything, and so that you can hear those also. The responses currently are non-public because by statute we can't release those until we actually make a decision. We'll be more than happy to share the names of the vendors, and I believe there'll be some that you know. Talking with senior staff at the hospital district, they're very pleased with the quality of some of the providers, or not providers, but those entities that submitted. So I think, you know, in somewhat of a encapsulated comment, I believe that we're well on our way, and I look forward, and I know the court looks forward to moving forward with this, having you all involved in it, and move forward with the process that we really originally established.
Thank you very much, Mr. Manius, for the update. Any questions? All right, we'll make sure.
Who
when,
paid the
when-
ticket?
Yeah, I was gonna say, when you come back,
Mr. Early paid the tickets.
we wanna make sure that we still have parking spaces over here, do we?
What parking places?
Well, I mean, it's, I could have predicted that.
I hadn't paid the ticket yet.
I'm glad I had my jury duty already this year.
Thank you.
All right, thanks a whole lot, GK.
We do, validate.
Yes, we appreciate that. We'll come see you personally about that validation.
You will.
All righty, so that concludes the regular agenda. There's no further action items, but we do need to have a short executive session. So at 5:06 PM, we will consider ourselves adjourned in the regular meeting, and we'll convene executive session, and we'll come back if any action is necessary following that meeting. What you got the other day?
5 o'clock someplace.
Unfortunately,
I think that may be what's doing it. I think it was on socks.
it's only 5 o'clock on the West Coast now.
Blame it on, blame JR on this one.
I got another meeting tonight.
I gotta run out here now.
All right, I'm gonna go get my car before GK has it towed.
I'm a working phase. You depended on Peter. I need to look over there.
Guys,
See if she be
y'all
doing
better go get
something.
your car before GK has